But today I'm going to talk about IV lipid emulsions and IFALD and all the different products and all the different approaches we've learned over the years. These are my disclosures. And our learning objectives for this session, we're going to talk about how these products were developed, why we didn't pick up on lipid emulsions being the bad player in regards to IFALD, and how we apply the currently available products in clinical practice. And of course, I'll be talking about off-label use of approved products. And for those of you who may or may not know, IV lipid emulsions were developed for patients receiving parenteral nutrition as a source of essential fatty acids and as an alternative to carbohydrates as a source of non-protein calories. And so why didn't we figure out why the lipids were the bad player and to predispose in patients to IFALD? Why wasn't it considered sooner? Well, we have to go back when PN was first developed. When Dr. Dudrick developed PN in the US back in the 1960s, it was a lipid-free process that relied on a high carbohydrate intake. He didn't have access to any lipid emulsions at the time. And so in order to prevent essential fatty acid deficiency, he used either blood transfusions of the parents' blood after they were fed a high-fat diet, or he applied topical oils to the patient. But regardless, the patient still developed liver disease. Meanwhile, back in Europe, they had access to intralipid that was developed in the 1960s. And it was used with an egg yolk phospholipid emulsifier that was developed by Dr. Retland, as you see in this picture next to Dr. Dudrick. And this allowed for a lower carbohydrate intake. However, their patients also developed liver disease. So as a result, we were left with a clinical conundrum. Liver disease happened with or without the presence of IV lipid emulsions, so as a result, we all concluded it wasn't the lipids. In fact, until recently, it was in the textbooks stated as such. So what's common to all lipid emulsions? Well, they all have that same egg yolk phospholipid emulsifier that Dr. Retland developed. There are no egg-free lipid emulsions, regardless of oil source, anywhere in the world today. They all contain glycerin to stabilize the emulsion. They contain sodium hydroxide to buffer the emulsion, and they also contain sterile water for injection. In fact, that's the biggest component of a lipid emulsion. Where do these products vary? Well, they vary in the vitamin E or alpha tocopherol content, the inflammatory characteristics due to the oil source, and the phytosterol content. And these aren't things you'll see on the product label. You have to go to the primary literature or ask the manufacturer for that information. So in the 21st century, we started thinking a little bit differently about liver disease and lipid emulsions. Back in 2000, Dr. Ginny Colombe in Paris suggested you hold the soybean oil lipid emulsions when patients had thrombocytopenia or liver disease, or you reduce the dose. And in the US, Patrick Javid, when he was in the Puder lab in Boston back in early part of this 2002, 2003, he showed that the route of administration of the soybean oil lipid emulsions made a difference in a mouse model of liver injury. If you gave the mouse the lipid emulsion orally, it was okay. If you gave soybean oil lipid emulsion IV, it wasn't. And later, Ian Oley, also in the Puder lab in Boston, he substituted the soybean oil with fish oil emulsion, and he showed that the route of administration no longer made a difference. You could give it either IV or orally, and they both were not hepatotoxic. So what's old is new? Well, actually, back in 1998, Kishore Iyer, who used to be a member of the Oley board, and Peter Clayton showed that it was actually the plant sterols or the phytosterols that were present in the soybean oil lipid emulsions may be the bad player in predisposing patients to PN-associated liver disease. So he discovered the problem, but he didn't have a solution because at that time in 1998, we didn't have any phytosterol-free lipid emulsions available. Omegaven wasn't around at that time. In fact, if we used it as monotherapy, people thought it would have caused essential fatty acid deficiency at that time, so it wouldn't have been on the radar. So we have the Puder lab at Boston Children's Hospital, and we started working on PN-associated liver injury back in 2002, and we thought it was due in part to the lipid components. And we developed a mouse model of liver injury. And the first thing, as I mentioned before, Patrick Javid and Dr. Puder and myself showed that the route of administration of soybean oil made a difference. We compare our mice to a normal chow-fed diet. We gave them PN alone with no fat. We gave them PN with oral soybean oil lipid emulsion, and then we gave them oral PN with IV soybean oil lipid emulsion, and we showed that the normal child had normal histology. When we gave the mice the PN with oral soybean oil, it was normal histology. PN with no fat had a fatty liver. And when we gave it with IV soybean oil lipid emulsion, it made a bad situation worse. So we knew there was something with the soybean oil when we gave it IV. So what about switching to the different type of lipid? That's when we switched to the use of fish oil-based lipid emulsions, and that was Ian Alwayn's research that we published in 2005. Same experiments, and what we did was we switched from soybean oil to fish oil, and as you can see here, when you gave it either IV or orally, the hepatic architecture remained intact. So we knew that fish oil was less hepatotoxic and more hepatoprotective. So why weren't other lipid emulsions considered? Well, actually, they were. We stumbled onto fish oil first, so that's what we stuck with. But we also imported all the different products that were available in Europe during this time and repeated the same series of experiments with the mixed oil lipid emulsions, whether it be the soy MCT olive and fish or the olive oil soybean oil emulsion. And we saw that the liver disease was very similar to what we saw with the pure soybean oil lipid emulsion, so we stuck with fish oil. So in 2004, we began the use of using pure fish oil in pediatric IFALD. And in our protocol, we stopped all forms of soybean oil. We gave fish oil lipid emulsion 1 gram per kilo per day for the remaining time the patient was on PN. And we made up for the loss of the non-protein calories as additional carbohydrate. And in 2009, we published our experiences in Annals of Surgery, and we showed that the death and transplant rates were lower in patients treated with fish oil in comparison to children who remained on soybean oil while they had IFALD. We showed that regardless of if you look at any of our papers, we showed the same pattern of decline in the mean direct bilirubin levels. Patients on fish oil tended to get better around 12 weeks after stopping all the soybean oil and going to fish oil monotherapy, while children who received soybean oil continuously continued to see worsening of their liver function, the bilirubin levels rising until they either transitioned to full enteral nutrition, received a transplant, or unfortunately passed away. People were concerned with this approach of using pure fish oil monotherapy. They thought patients would get essential fatty acid deficient or not grow as well. And last year in 2020, the data that we used to get the new drug application approved for the fish oil monotherapy, we had a multi-center trial looking at from UCLA, Boston, and Texas Children's, and we showed that both growth and essential fatty acid status was maintained in patients with IFALD, whether they got fish oil monotherapy or soybean oil monotherapy. So we showed that growth was definitely the same or better. So what about other lipid strategies? Well, for prevention, we first look at the impact of soybean oil lipid dose, because as you mentioned, our dose is 1 gram per kilo per day. So as many people thought, perhaps that's why our patients did better, because it was lower dose, like Dr. Colombo alluded to him back in 2000. And Rollins and group in 2013 out of Utah did a prospective randomized controlled trial in infants receiving PN, either 1 gram per kilo to 3 grams per kilo per day, and show that the rate of increase in the liver function test was lower in the patients that received low-dose lipid emulsion, and none of them got essential fatty acid deficient. So a lot of people started changing practice based on these results. Likewise, in Seattle Children, Sanchez and Javid, the same Javid that worked with us at our lab, did the similar study in surgical neonates, which received either 1 gram per kilo or 2 grams per kilo per day of pure soybean oil lipid emulsion. And they also saw that liver disease happened in both groups, although lower in the low-dose lipid group, soybean oil lipid group, and they still had to use fish oil monotherapy to rescue them, although the incidence was lower. And then there was another approach that also came out of Michigan. Dr. Dan Teitelbaum and Petrea Koba, they did what we call a severe soybean oil lipid restriction, where they gave 1 gram per kilo per day only twice a week, and they monitored essential fatty acid status. And they showed a statistical important reduction in total bilirubin levels with this approach. However, there was a multi-center trial that came out of UCLA, Yale, and Chicago, where they looked at a group of neonates that were randomized to either 1 gram or 3 grams per kilo per day of pure soybean oil. And they saw absolutely no difference. More importantly, they also showed that if you got the 1 gram per kilo per day dosing, there was no negative outcome on growth. So that was important to consider. And this was similar to our experience at Boston Children's. Because practice changed, not everybody in Boston got Omegaven. A lot of kids just went to soybean oil lipid restriction. And so we looked at our incidence and we compared a gram per kilo per day to 2 to 3 grams per kilo per day. And we saw that it didn't really make a difference. The incidence of IFALD or cholestasis was the same in both groups. So we also did a prevention trial using fish oil monotherapy. We were funded by the March of Dimes and the FDA Orphan Drug Development Program. And in our study, we prospectively randomized children to either 1 to 3 gram per kilo per day of fish oil or 1 gram per kilo per day of soybean oil. But because we're not a birthing hospital, we get babies transferred in. Our patients tended to be healthy because one of the exclusion criteria was you could not be exposed to any form of lipid emulsion before you started the study. So that knocked out a lot of the babies that come to us from other hospitals, like the necrotizing enterocolitis patients. So we pretty much had a group of gastroschisis babies. And as a result, we saw really no difference in the incidence of cholestasis with this approach. In fact, most of these kids were off PM by almost after 30 days. But we also noticed that the use of fish oil monotherapy was safe. So that was important. There was no negative effects on growth, infection, or fatty acid profiles, or neurodevelopment. So what about treatment? Well, one of the biggest criticisms of the research we've done is that we did not do the gold standard of a randomized controlled trial prospectively comparing equal doses of fish or soybean oil lipid emulsion to patients with IFALD. But however, there was a group in Hong Kong led by Dr. Hugh Lam that did this study. And I really strongly suggest you read this paper, but not for the reasons that you would think. In this study, they both received 1.5 grams per kilo per day of the lipid emulsion. And it was originally designed for children, a total of 40 children. However, they only published 16 patients. And the outcome that was supposed to be the reversal rate of IFALD at 4 months between the two groups. At that time, they showed that the increase in bilirubin levels was greater in the soybean oil treated group in comparison to fish oil, and that the kids that get in the fish oil had a greater rate of advancement of enteral nutrition. But the most important thing is that the reason why the study was stopped. What happened was, as people started hearing about fish oil monotherapy, parents did not want their child to be randomized to the soybean oil arm, so they refused to be part of the study. They had trouble recruiting, so they stopped the study and published what they had for data. And what's important about this paper is it influenced the FDA to accept historical controls when they came to review the new drug application in the United States. We didn't have to do the prospective randomized control trial because there was no longer any equipoise. So that's why you don't see that RCT in the US. So if you're interested, read the paper, because that's an important part of the story. However, knowing that, we also know that fish oil Omegaven is not a wonder drug. Not everybody gets better. Some patients, unfortunately, have to go on to transplants. Some patients do die. So we looked at our data to find out why that happened. We looked at all our patients that didn't respond to the therapy, and we identified 4 different independent predictors of treatment failure. We saw that patients who had PELD scores greater than 15 at the time of enrollment, a history of a GI bleed, the patients who had IFALD for more than 16 weeks before they started receiving fish oil monotherapy, or being on a ventilator. All these seem to predispose a higher rate of treatment failure. But that being said, there were patients that did get better despite having these predictive factors. And there were patients who didn't have these factors who also succumbed. So again, it just made us think, and we understand that nothing is perfect and we have to do more. There have been other approaches with other lipid emulsions, and we'll talk about the different products that are available in the next series of slides. In the United Kingdom, they had access to the soy, MCT, olive, and fish oil earlier than the US. And in the United Kingdom, they did do a case series of 8 children who had IFALD, who was switched from soybean oil to the mixed oil emulsion. And in this case series, 1 patient died, 1 patient went on to transplant, but the remaining 6 had a similar trajectory of decline of the bilirubin levels 1 to 3 months after switching. So it did show benefit. And also in Toronto, Lamb in 2018, in their study at sick kids, they compared 2.2 gram per kilo per day dosing between the mixed oil lipid emulsion to pure soybean oil, and they showed that there was clinical improvement in the patients that got the mixed oil emulsion. That being said, you have to think about dose at essential fatty acid status. And Carey out of Boston Children's in 2018 had a case series of 4 children who did receive that mixed oil emulsion at the lower dosing and had developed essential fatty acid deficiency. They also had a history of IFALD. So all these children had to be switched to fish oil monotherapy in order to correct the essential fatty acid deficiency. And one of the big things that was suggested was, you had a risk to benefit. In order to prevent the essential fatty acid deficiency, you had to give it a dose that was similar to a gram per kilo per day of soybean oil, which translates to approximately 3 grams per kilo per day of the mixed oil lipid emulsion. And in fact, there was a paper that came out of Vienna by Reppe and colleagues out of Vienna, Austria, that suggests that maybe the higher dose of the soy, MCT, olive, and fish oil may blunt the hepatoprotective response. And in fact, you may have to, in their study, these extremely low birth weight infants were randomized to either the mixed oil or the pure soybean oil up to a dose of 3 grams per kilo per day, and they saw no difference. In Canada, before they had access to this composite lipid emulsion, they actually did a blend of 50-50 between fish oil and soybean oil. And in their case series, they did 12 patients with IFALD and were treated this way. And of those 12 patients, in 5 cases, they had to actually stop all the soybean oil before they saw clinical improvement in the fish oil. And the reason they even did the blend was that they thought that fish oil alone would cause essential fatty acid deficiency. So that's why they added the soybean oil. But we've since learned you can give it, in fact, safely as monotherapy. And in fact, in this case series of 12 patients, no patients died, and resolution happened in a total of 9 patients. So some did get better on the blend, but the remaining patients had to go on to transplant, but there were no deaths. Again, Michigan did another approach with the soy lipid restriction. Again, they restricted down to 1 gram per kilo per day, twice a week. And they also showed that they saw clinical improvement in comparison to pure soybean oil at the traditional dosing. Now, what about on the olive oil, soybean oil approach? Unfortunately, I'm not aware of any studies conducted in the U.S. in children. It's not approved for use in kids. So I have to rely on this data that came from Europe. Paulik and colleagues did do a prospective RCT where they're actually looking at retinopathy of prematurity as the primary outcome, but they did look at liver disease as a secondary outcome. And what they did was they used the olive oil, soy, with and without fish oil. And they showed that the infants that got the fish oil plus the olive soy actually had a lower incidence of retinopathy of prematurity, which is a form of neonatal blindness. And they also had a lower incidence of IFALD. Similarly, there was a study that came out of Finland where they had 5 premature infants. It was a case series where they did a 1-to-1 blend of fish oil plus the olive soybean oil lipid emulsion. And they showed normalization of the hepatic function within a year after starting this therapy. So the key takeaways from this, I know I went quickly, but hopefully the questions will be answered through the rest of the afternoon with other sessions. There are many pros and cons with soybean oil lipid emulsion. The pros are we've been using this for more than 50 years. We have a lot of experience. We know at doses of 1 gram per kilo per day, you're not going to get essential fatty acid deficiency, and we have tons of compatibility data. The cons are, as we know, because of the high phytosterol content, the high content of a pro-inflammatory omega-6 fatty acids, there's a higher incidence of IFALD. There's also a lower incidence of the hepatoprotective vitamin E in the form of alpha tocopherol. Fish oil, we know as a pro, improves hepatic function, has a high content of less pro-inflammatory omega-3 fatty acids, has higher amounts of vitamin E, naturally lower in phytosterols, there's no black box warning. The cons are you need to give at least 1 gram per kilo per day to prevent essential fatty acid deficiency. It's a 10% emulsion, so it's twice the volume in comparison to the other products. And there's very little compatibility information, though I understand there's studies forthcoming. With the composite soy, MCT, olive, and fish oil lipid emulsion, again, it's 20%. You can give lower doses of carbohydrates because you can give more higher doses of this lipid emulsion, so you can reduce the glucose infusion rate, so it makes it easier to cycle patients. Has MCT oil, which improves the stability of a total nutrient admixture. It does have DHA, arachidotic acid, less soybean oil, so you do have better fatty acid profiles. However, you have to give 3 grams per kilo per day to give equivalent amount of 1 gram per kilo per day of soybean oil. It's currently not FDA approved for use in pediatrics, so it's off-label when you use it that way. Studies are on the way. And there's also very limited compatibility data. So again, there's studies forthcoming, but right now we don't have that data. With olive oil, soybean oil, again, it's a 20% emulsion. So again, you can use it the same way you use the other emulsion to reduce the GIR. It has less of the pro-inflammatory omega-6 fatty acids because 80% of it is olive oil, which is an oleic acid. However, you cannot use it in a soy lipid restriction protocol. You have to give it at the labeled dose. There's very few US studies. You have to rely on the European literature. And there's very limited compatibility data. As I mentioned previously, it's currently not approved for use in pediatric patients. So another thing to remember is, despite seeing the hepatoprotective benefits, normalization of bilirubin levels, resolution of jaundice, as Sam Kokocious out of Cincinnati Children's has stated, even when the wound is healed, the scar remains. Patients, we don't biopsy. Once your numbers look good, you're not going to have somebody biopsy just to see what's what. So there could be ongoing fibrosis. So there's still much more that we have to learn. So again, we're still not out of the woods yet. So what should you use? Well, these are my rules, okay? I'm take the hit for this. This is my approach. Nobody else is at Boston. This is what I say. I say can't hang them. Let's hang me. We use all 3 different products. We use pure soybean oil, pure fish oil, and the MCT olive and fish oil to prevent essential fatty acids. IFALD, we go with the 1 gram per kilo per day soybean monotherapy in our patients who are fluid restricted, for patients who have limited vascular access, lots of parenteral medications. Why? Because we have a lot of good compatibility information, and we know we won't cause essential fatty acid deficiency. We may also consider using age-appropriate dosing of the soy, MCT, olive, and fish oil, or you might even, for an older patient, I have no personal experience, the olive soy, because that would allow you to reduce your carbohydrate load provided by the PN. Again, you'd have to rely on the European literature, especially for the olive soybean oil pediatric dosing, because there's nothing out there in the US literature. And once the patient does go on to develop IFALD, well, we have to do what we've always done. We have to encourage enteral nutrition when it's safe to do so. That's the most curative practice. And if we have to do this, we have to go to fish oil monotherapy at a dose of 1 to 1.5 grams per kilo per day. We go with the higher dose, especially if we want to decrease the glucose infusion rate, again, to help with cycling. And also if a patient is malnourished, we've learned that this is actually a bit more beneficial. So this, I'll close. As again, it's clear as mud. I probably left you with more questions than answers. Thank you.